Educational content by Dr. Mohammed Al-Naji Mohammed.
All right, welcome. Today we're doing a high-yield review of GLP-1 modulators. We're going to break down everything you need to know about these drugs, focusing on the key info for your daily practice, and of course, for those specialty exams like the MRCGP, AKT.
So here's our game plan. We'll start with the core physiology, the incretin effect. Then, we'll jump into the two main drug classes that tap into this pathway, the GLP-1 mimetics and the DP4 inhibitors. And we'll wrap it all up with a head-to-head comparison to make sure everything really sticks.
Okay, first things first. To really get how these drugs work, we have to start with the fundamental physiology, and that means understanding the incretin effect.
So what in the world is the incretin effect? Well, it's this really fascinating phenomenon where if you take in glucose by mouth, by eating something, your body releases a lot more insulin than if you got the exact same amount of glucose straight into your vein through an IV. This tells us the gut isn't just a passive tube. It's actively sending out hormone signals to get the pancreas prepped and ready.
And this slide just shows it perfectly. Look at the left. Give someone IV glucose, and you get a pretty modest insulin release. But now look at the right. Give them that same glucose orally, and boom, you get this massively amplified insulin response. That huge difference between the two, that is the incretin effect.
And the main player making this all happen is a hormone called glucagon-like peptide 1, or GLP-1 for short. It's released from the gut after you eat, and it's the messenger that tells the pancreas, hey, get ready to release some insulin.
So here's where it all becomes clinically relevant. In folks with type 2 diabetes, this whole incretin system is basically broken. The effect is blunted, meaning they don't get that big insulin surge after a meal, which contributes to high blood sugar. And this, right here, gives us a perfect target for our drugs.
Which brings us to our first class of drugs, the GLP-1 mimetics. You can also call them GLP-1 receptor agonists. These are drugs we give from the outside to mimic or replace the body's own GLP-1.
So how do they work? It's really a three-step process. First, they copy the action of GLP-1 and stimulate insulin release. But here's the clever part. It's glucose-dependent. They only work when blood sugar is high, which means a really low risk of causing hypos. Second, they tell the pancreas to stop releasing glucagon, which lowers sugar production in the liver. And third, they slow down how quickly your stomach empties, which is a key part of their other effects.
And that leads us to one of their biggest selling points. Unlike so many other diabetes meds that cause weight gain, GLP-1 mimetics actually cause weight loss. This happens because of that delayed stomach emptying we just mentioned, plus they work on the brain to make you feel fuller. For a lot of patients with type 2 diabetes who are also dealing with obesity, this is a massive win.
Now, for anyone prepping for exams, you absolutely have to know the NICE guidance. You'll want to think about adding a GLP-1 mimetic if a patient is already on dual therapy and their BMI is 35 or higher. There's an exception for a lower BMI, though. You might use it if insulin is a no-go for some reason, say for a professional driver, or if losing weight would be a huge help for other serious health problems they have.
And here's another critical point for exams and practice. This isn't a fire and forget medication. NICE is very clear. You have to review the patient at 6 months. And to keep them on it, they need to hit two specific targets. Their hemoglobin A1C has to drop by at least 1%, and they have to have lost at least 3% of their body weight. Both have to be met.
So how are these given? They're all subcutaneous injections. Exenatide, the standard one, is a twice-a-day shot you take before meals. Liraglutide, on the other hand, is longer acting, so it's a much more convenient once-a-day injection.
Now, thinking about how these drugs work, especially with that delayed stomach emptying, what do you think is the most common side effect people complain about when they start?
You got it. It's all about the gut. The number one complaint is nausea, sometimes with vomiting, especially when patients first start the medication. It's a key thing to warn patients about, but also reassure them that for many, it does get better over time.
But beyond those common side effects, there's a more serious, though much rarer risk that the regulators have flagged up.
And this is a big one. The MHRA has put out a specific warning about a link between exenatide and cases of severe acute pancreatitis. This is a red flag you cannot ignore. If a patient on one of these drugs comes in with severe, persistent stomach pain, especially if it's going through to their back, you have to think pancreatitis and get them checked out urgently.
Okay, let's switch gears now to the second group of incretin drugs, the DPP4 inhibitors, or, as you'll often hear them called, the gliptins.
So these guys work a little differently. Instead of adding an external GLP-1 mimetic, they work by protecting the GLP-1 your body already makes. See, there's an enzyme called DPP4 that breaks down your natural incretins really fast. These drugs block that enzyme, which lets your own GLP-1 and GIP hang around longer and work harder. Pretty clever, right?
And their clinical profile is really distinct. First off, they're pills, not injections, which is a big plus for a lot of people. They're usually very well tolerated, have that same low risk of hypos, and, this is a key difference, they don't cause weight gain. They're weight neutral.
Okay, so that brings us to the big question, when do you use which one? Let's put them side by side in a high-yield summary to really nail down their differences.
This table is pure gold for revision. On one hand, you have the GLP-1 mimetics. They're injectable, powerful, and cause weight loss, but you've got to watch out for those GI side effects. On the other hand, the DPP-4 inhibitors. They're oral, weight neutral, and super easy to tolerate, but maybe a bit more modest in their effect. So the choice really comes down to the patient in front of you, their BMI, their preferences, and how much you need to lower their HbA1c.
Let's end with a quick clinical case to put it all together. You have a patient on metformin and a sulfonylurea. Their BMI is 36. Thinking back to the nice guidance we covered, which of these drug classes should be next on your list? This is exactly the kind of question that tests if you can apply this knowledge in the real world.